Now, what ended up scaring them away was it got pulled off the FDA shortage list, and that's when they stopped the process. But he then gave a presentation of every single thing that they had looked at in terms of safety and efficacy and all of those related things on what they should be looking for a good qualified compounding pharmacy, good API. It was very informative. But he said some very I'm going to say pro-patient things towards the end, and I felt like one of them in particular was kind of calling out his colleagues a little bit, and that's why I said they put the good cop first. Because he said at the end, he goes, even with today's news of the price reduction, these branded medications may still be out of the reach for some people, and there are going to be people who choose to still use compound. First of all, then he followed that up with the fact that as physicians, we need to make patients comfortable with us to tell us they're using compound rather than hiding it from us, from the shame perspective. But more importantly, he said it is our responsibility to care for these patients and make sure that they are doing it safely.
Yes.
Amen.
Hallelujah. That is exactly right.
Hell yeah.
Oh, but wait.
Oh, God.
Yeah. I don't recall a physician up until that point in time, like me actually being in a room or hearing one say that about compound.
Yeah.
Like that was big for me to hear. But then it got worse.
Oh, God.
Oh.
And then
that is a good analogy, Mike. The second speaker was a pharmacist.
Yeah.
And she basically broke down, okay, well, yes, there are these different APIs and there are all these different places where you can get compound. And some of these places are not putting in the compound the same API that is being used in the branded. So Semasalt is the one that kind of came up as the common denominator. It's not the same form that Novo is using, but some of the compounders are using the same form and some of them aren't. And the one that isn't studied and isn't, approved. So they were liking that more towards gray or black market, but they stopped short of calling that particular one because it was at least being produced by a 503A compounding pharmacy.
Yeah.
But then they got into the gray research, and this is where she gets her stars for her presentation, because this is one of the first presentations I've actually sat through where they've made it differentiation between compound, gray, and black market.
Wow.
Because they separated them in terms of the presentation.
Oh,
it's basically like what, Mike?
There's someone here on TikTok who apparently was in that session who says that woman's data was not broken out.
Interesting.
Just
not broken out between gray and black.
You're in the science zone. But I was surprised when I saw that today because you had told me that.
I mean, it wasn't perfectly broken out, but it was broken out to the point where they did have a slide on gray and black market, and they called them the research grade loopholes, or research chemicals is the term she used for that.
Okay.
So yeah, the whole thing was about, though, her presentation as a pharmacist seemed to be around the adverse events and pulling this data about dose. She called them dosing misadventures, as well, about how people didn't really know what their doses. And all of us have been on TikTok, and we've said your dose is not your units.
Yeah.
And the problem that she was also getting at was that not every compounding pharmacy was making them to the same concentration or doing it the same way. So there was no unilateral policy. So it made it more confusing for a doctor, their actual in-person doctor. They were having to bring the prescriptions into them, or they were just using it incorrectly. I think all of us also know that we've heard stories of people using the branded incorrectly, though, as well, especially when the vials came out.
Yes.
So, I think that there needs to be better data on that.
I mean, we know there's people that take the pens and empty the pens, right? They buy brand and empty the pens into vials and dose how they feel like that's the thing is I think like I hate when we see it on TikTok when someone will say they've OD'd, like I'm going to say, cause I'm not sure about what I can say on the YT here, but they've used that language, right? As opposed to like dosing misadventures, which is like, I feel like what you're like talking about, right? It's an interesting way to put it. Like I'm wondering too, like, because that is the distinction that we've seen. So when we've done some great episodes on the podcast, investigation only, to be clear, where we were learning about from our gray friends, right, the difference between all of that. And so like what they've told us, for those our listeners who are just listening, who haven't seen that episode, so we've talked about what is the gray market. And so my gray friends, or when I say our gray friends, we mean the gray community. They are a community in and of themselves, and they are also part of GLP-1 community, that they talk about how getting like research grade peptides, which is domestic gray. And then they also have the difference where it's, from China or an API elsewhere, where they get that through peptide companies. And both of these ways, they come to you and you mix them up at home and you dose them accordingly on your own. There is no doctor, there is no oversight. If anything, they're from a patient perspective, and communities, they lean on each other for support in this area. And there are many people from the gray community that are like, not everybody should go gray, for exactly the reason that we're talking about, units versus milligrams versus, all these different things. Like it's not for everyone. And the only reason, for the most part, I have found in my research that people even do gray peptide here is because of the price, right? Or they do gray peptide overseas is because of the price. And it's usually people, I think there are some people, like we talked to Dave about in our last episode, where people maybe are doing this to get skinny. Okay, fine, whatever. Let's just, I don't think that's the majority of the people. I do think it's people who struggle metabolically for whatever reason or whatever spectrum, and they're sick and they just need their medicine. And they're trying to get it the best way that they can. And in the gray, when you're buying it like overseas, they have buying groups where they buy it together, they test it together, and then they split it, right? And they're paying $500 a year for their medicine instead of $500 a month. And this is massive booming business since, honestly, the shortage stopped and a lot of people pulled back in the way that Zach is talking about. So that's been a big change. I can't help but wonder what this, more accessibility will do to the gray market or domestic gray or, overseas. I can't even speculate on that because my head's still exploding from what we just learned a week ago,
I think the people doing gray will just keep doing gray.
Yeah.
Because once you start doing it, you see how much money you've saved and you're comfortable with it. And then there's no reason to stop unless laws change and things become more difficult to get.
Yes.
But I think that those people are going to stay gray, just like some people who are already using compound medication with their pharmacies are going to stay with a telehealth company that's giving them compound. And the reason why, I think, is because they have like a full spectrum of support that you don't get just from going to your family practitioner, getting your little pen and going home with it, where you have like support group and community. You have sometimes like mental health support and nutrition and fitness. And like when you have all of that, why would you want to give that up?
Honestly, I'm pretty sure that's why Weight Watchers stayed in the market as long as they did as the leader, because that's exactly what they did. It was the diet you need forever, and you had the whole system baked in. Your community was there. You went and did weigh-ins, and you did things with your community. You had friends. They went to your wedding. Like, it was all baked in. So I see where you're going with that. I also think that ultimately we do have friends that do gray that are peptides that have not been approved yet. So we have friends that do peptides that are like what is it called? Cagrilintide, right? Or they do Retta, right? We want to be careful saying that, but they do Retta, right? And Retta has not been approved by the FDA for anything yet. So those people, I think, if they feel success with that, are going to keep doing it. But most people I've talked to in gray have all still said to me, most people, that it is a last resort. Like, it is a last resort. But I really do think that if you give people the choice, right? $25 at your pharmacy. I do think for the most part, they're going to go that direction. Unless it's, again,
I agree.
different peptide, different reasons. You know what I mean?
And isn't that the dream? I mean, despite all of everything that's going on right now, the dream is for all of us to be able to get a prescription from our doctor that we're qualified for, and walk in without a PA net process necessary into our CVS or Walgreens or a local pharmacy and pick up a box for $25 to $50. Like that is what we need to continue to fight for.
Yes. Yeah. And I think we have other people in the community that support the community in different ways, right? Whether it is, understanding these things because they don't have access, right? Because of this massive issue and I think that for a lot of us here, what we're trying to do is move that needle, right? We're trying to move access and quality care, which is why we want TROA to pass too, because there's a lot of pieces of care that people are very worthy and deserving, and that is necessary, not just being on these medicines, but because they have the disease. And there's a lot of limitations, right, with Medicare right now. And we want that to change. We want that to get better. All right. What other pens do we miss, friends? Else?
I would say let me put one in that's hasn't been said, but
let's do it.
I think it's one that people will be super interested in. And Zach and I have some disagreements on it, but Dr. Mitch Bierman out of San Diego did a paper. It's more than a case study, which is a single case, less than a study, right? Because it's only 30 people out of his clinic. But he looked at people under BMI of 35 or 35 and under, who had reached either their health goals, or they had reached their goal weight, or two of the three of these, or they wanted to come off meds. And as long as they met either their health goal, their weight goal, he would take them off. And of the 26, he dosed them at every other week. And of the 30, 26 of them did not gain weight after a year. 4 of them did. It was an interesting study that they're going to, the goal of this is to start to bring it in to have it further researched out. But one of the things that I really took away from the conference was how many things like that if you live in the TikTok or the YouTube community and you absorb lots and lots of cases like we do, where we listen to tons of people's stories, how many things we sort of accept here as sort of like, oh yeah, we kind of know this. So many of the studies that we saw were that they were just trying to put a data point and study on our lived experience. So Dr. Desmina, I can't remember her last name, it begins with a B, out of UC Davis, was funded by Known Well Clinics, and did a study looking at how our food choices change after 6 months. Now, we all know that we all move towards whole foods, but to actually be building towards that, or how when we started GLP-1, there was another study about how many of us are doing more exercise as a result of it.